In this episode, we'll find out how American Academy of Dermatology President Daniel Siegel celebrated $1 million in contributions to SkinPack.
We'll hear about the skin conditions that are continuing to plague HIV patients.
We bring you the 5 hottest stories on skinandallergynews.com.
And our contributing dermatologist, Dr. Lily Talakub, talks about adult acne.
Welcome to our dermatology show, the Skinny Vodcast. I'm Amy Pfeiffer.
And I'm Terry Rudd.
The American Academy of Dermatology's Summer Academy meeting took place last month in Boston. And not only did I attend, but I got to watch Dr. Siegel get his head shaved to fulfill a promise to the AAD's Political Action Committee. He was a really good sport.
Okay, Dan, don't move. Ah!
Move over, Captain Jean-Luc Picard. There's a new bald man in town. To make good on a promise, American Academy of Dermatology President Dr. Daniel Siegel had his head publicly shaved at the Summer Academy meeting in Boston to celebrate $1 million in contributions made to SkinPack, the AAD's Political Action Committee. Members contributing the maximum donation amount of $5,000 got to take turns shaving Dr. Siegel's locks. He pledged that if SkinPack was able to build on the successes of previous years and hit the $1 million mark for the 2012 election cycle, he would go bald. And go bald he did. Can you just tell us a little bit about SkinPack and why it's such an important program?
SkinPack is the only political action committee for the entire specialty of dermatology. We're the only national PAC for dermatology and dermatologists. We've donated to members of both parties. The important thing is we donate to the leadership and to the people who support our interests and our concerns. We want better care for our patients. Patient safety is important. Revocation of the IPAB is important, and a long-lasting SGR fix is critical. And the people who support us will support them. But if you don't support us, watch out. There's Congressman Brian Bilbray in Southern California. His daughter suffers from stage 3 melanoma. He was kind enough to do a video for us recently, and he's become an advocate for melanoma research and for prevention and treatment of skin cancer. And that's someone we support.
Okay, excellent. Well, you look fantastic. Can I touch it?
Go for it.
Very nice. I think you're going to start a new trend.
I'm hoping so.
Thank you so much.
Thank you, Amy.
You may not look so bad bald either, Terry.
Yeah, thanks, but I'll leave that to Dr. Siegel and Patrick Stewart. While therapeutic advances were celebrated at the International AIDS Conference this summer, a dermatologist who is also an HIV expert reminded us that there are some complications that just won't go away.
In the earliest days of the AIDS epidemic, doctors at San Francisco General Hospital started seeing cases of Kaposi sarcoma in young men. Now an old problem is back. Dr. Kieran Leslie of San Francisco General's famed Ward 86 explains.
Because patients are living longer, we're seeing diseases that we see in older people. So a lot of our patients today have got non-melanoma skin cancer, which is increased risk in HIV infection, even when you have well-controlled HIV. The Kaposi's is an interesting story because, of course, we were seeing tons of Kaposi's up to 1996. And then for maybe 5-10 years, the incidence really went down to negligible levels. But over the last 6 or 7 years, in San Francisco at least, we've been seeing an increasing number of Kaposi sarcoma patients. And these patients are, there's a whole mix of patients. Some of the patients are very much like the old-fashioned patients with very low CD4 counts who've just not accessed care or were not diagnosed with HIV. Other patients are known HIV patients with good immune systems with a high CD4 count. And we've got a growing group now of patients with long-term HIV infection, well controlled. They've been on every antiretroviral regime and always adhered to therapy. And despite great T-cell counts and undetectable viral load, they're presenting now with Kaposi sarcoma, which is a new development. We desperately need better treatments for Kaposi sarcoma because even the best chemotherapy that we have, still a sizable proportion of patients do not clear. So that would be a big challenge. I think looking ahead, we're concerned with the rise in other skin cancers that we're seeing, especially with an aging population. We've known epidemiologically that the non-melanoma skin cancer is increased in HIV, both basal cell cancers and squamous cell cancers, and indeed melanoma as well. What we've sort of recently been seeing is some pretty highly aggressive tumours and recurrent tumours in our HIV patients. I think the dermatologists should be aware of the great hope that the AIDS 2012 conference showed. There may not be an end in sight in terms of cure, but there is great progress in terms of preventing infection with pre-exposure prophylaxis. There's the first successful vaccine trial in some populations in Thailand was announced. There is the difficulties are that despite all the advances that have been made, in the United States only 28% of patients with HIV infection have the virus fully controlled. So still there are many people out there who don't know their HIV infection or are not on meds, even in the United States, which is a big problem.
Summer must really be coming to an end because it's time again to wrap up the most viewed stories on the Skin and Allergy News website.
One of the most popular articles was drug samples found to sway acne prescribing. The news article highlighted a study showing that newly diagnosed acne patients were almost 75% more likely to be prescribed branded medications if the clinic where they were treated offered free drug samples.
Another popular article was Dr. Leslie Bauman's cosmeceutical critique column on red light, where she noticed that adding red light to blue light can help speed the resolution of inflammatory acne lesions.
In clinical trials may overestimate benefits of psoriasis drugs, the results of a new comparative effectiveness study indicated that common psoriasis treatments aren't as effective in the real world as they are in clinical trials.
Also popular was our story, Psoriatic Arthritis Screening Tests Are Deemed Inadequate. Researchers tested 3 popular self-administered screening questionnaires for psoriatic arthritis and found that all 3 performed poorly when it came to differentiating between psoriatic arthritis, other arthritis, and fibromyalgia.
And finally, in the news article titled Expert, Reclaim Radiation for Skin Cancer, Dr. William Roth said that an elderly patient with basal cell or squamous cell carcinoma on the face or leg is the perfect candidate for radiation therapy.
All right. Let's move on to Cosmetic Counter. This month, Dr. Lily Talakoob discusses an increasingly common patient complaint, adult acne. Dr. Talakoob, who practices in McLean, Virginia, breaks down the causes of adult acne and offers tips on counseling your patients.
Today I'm going to be talking about acne in adult skin. One of my patients one time said, if I earn wrinkles, I shouldn't be earning pimples. However, we've seen a rapid increase in adult acne. Patients with adult acne oftentimes present with large, cystic, painful nodules underneath the skin, around the chin, the jaw, the back of the neck. These acne lesions are oftentimes triggered by hormones in the body. The hormones fluctuate around the period and also can increase around perimenopause or menopause. Hormonal acne is oftentimes very difficult to treat and very frustrating for patients. Approximately 45% of adult women between the ages of 21 and 30 develop hormonal acne, about 25% between the ages of 31 and 40, and about 15% between the ages of 41 and 50. Hormonal acne has several causes. The hormones around the period can induce the oil glands to overproduce oil and produce these cystic nodules, as well as a diet rich in hormonal foods such as dairy and non-organic meats. Oftentimes, oral treatment is required for hormonal acne. Topical treatments alone do not often treat the problem. The treatment courses for our patients with hormonal acne include oral contraceptive pills as well as oral medicines like spironolactone that block the hormones that induce these triggers. In addition, topical agents can be used with the oral treatments. Topical agents such as topical dapsone, topical azelaic acid are very effective when used in combination with oral treatments. However, agents that we use for teenage acne, such as benzoyl peroxide and retinoic acid, oftentimes do not help. Often I counsel my patients with hormonal acne that this is a long-term treatment requiring oral medicine in addition to a topical regimen, as well as dietary changes to produce effective results for hormonal acne. It's a frustrating problem, and it is it is a frustrating problem, and it is very much increased in the last decade or so. The way I counsel my patients is that oral and topical treatments are necessary, as well as dietary changes to treat the cystic, nodulous cystic acne that occurs for hormonal acne patients.
Well, that's it for us. Make sure to visit skinandallergynews.com for the latest dermatology news.
And we've got a free iPhone app. Search for Skin and Allergy News in the iTunes Store. Thanks for watching, and see you in November.